I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to give an introduction to the techniques in peripheral vascular intervention. So, digital subtraction and geography is extremely important for all sorts of peripheral interventions. The benefit is that the bone shadow disappears and therefore the arterial vasculature is very clear. So you can compare here, you can see the common femoral and then dividing into superficial femoral and profunda, and you can see how the bone is and how the branches are looking like. But look, once you do the digital subtraction instead of cine, you can see the bone shadow has completely disappeared and each and every branch is very evident now. Similarly, you can look over here. It's an REO view, AP view, and now this is in the LEO view. You can see how clear these arteries are. Another example, when you do below knee interventions, you can see how difficult it is to differentiate this artery from the bone. But over here you can easily see exactly what's happening, and this is the DSA. So again, you can compare DSA with cine here. So in the foot, you can see how the bone shadows are making things difficult. But once you do the DSA, the bone shadow disappears, and now you can very clearly see all the small branches even. So for all peripheral interventions, use DSA, that's digital subtraction and geography, instead of cine. Then it's important to look at different views, different angulations. So if you look at this right internal, external iliac artery, you can see it's totally occluded, but it's best seen in REO projection in this. So if you see over here, it's very difficult to exactly see where the point of occlusion is. Again, you can see something over here, but it's not very evident. But once you go into the REO view, you can see that the proximal cap is now very evident. This is the internal iliac artery, common iliac artery, and the external iliac artery is totally occluded here. So you must look at different views. Now if you want to do the intervention, you can see in the LEO view, again, this is not very clear, but if you look at the REO view here, you can see that the stump is very clear. You can see the clear line of occlusion, and you can see the distal artery appearing here in this region. So now you know exactly where to go with your wire. Again, importance of changing views, you can see here, that's the anterior tibial artery, then the common peroneal artery. This is the posterior tibial and the peroneal artery. You can see the posterior tibial and the peroneal artery are quite overlapping in this REO view, but once you go into the LEO, they open up very nicely. Again, you can see the difference between REO view and LEO view, and you can select the best view depending on which segment of the artery and which artery you want to intervene on. This is a very nice thing to do. If you put a tape measure is attached on the limb, you can actually do lesion lengths with that. Over here you can exactly see how long the lesion will be, what length of stent you need, what size of balloon you need. So you save a lot of contrast and radiation by using this measuring tape, and the accuracy also increases. Again, you can see over here, you can see that the measuring tape is there, makes life very easy to size and reduces contrast and radiation. And if you use the roadmap or overlay, what that is, in all peripheral interventions, again, you use this technology where you have you've taken the DSA and then you ask your machine operator to do an overlay or a roadmap. You can see the whole artery is visible to you as a white shadow in the background, and you are doing live imaging on top of it, and therefore you can easily place your stents. You exactly see where you need to start, where you need to go. So this overlay is very helpful. In addition to the measuring tape, you can also have the overlay, and you know where to start and where to finish your stent and how to go about it. So in peripheral inventory, it's a huge inventory, because in coronaries we have 0.014 wires, 0.014 wires, but in peripheral you have 0.014 wires, then you have a 0.018 wire and a 0.035 wire. So all three wires are used in peripheral interventions, and then according to the wire platform you have their balloons. So you have balloons with the compatible with 0.014 wire, balloons compatible with 0.018 wires, balloon compatible with 0.035 wires. And then for each balloon, for each of these platforms, you have two types of balloons further. One is a monorail balloon, the other is an over the wire balloon. And then in each one of them, you have shaft lengths 40 centimeters, 75 centimeters, 90 centimeters, 150 centimeters. So it's a huge inventory to maintain as compared to the coronary inventory. And in the stents again, you have stents compatible with 0.014 wire platform, 0.018 wire platform, 0.035 wire platform, and then the stents in all these three platforms can be either balloon mounted or self-expanding, and then they have different shaft lengths available. And then you have, according to the wire sport system, you have sport catheters, or you can say micro catheters of the peripheral circulation, which are helpful in exchanging wires, crossing the lesions, giving contrast injections, tip injections. So you have sport catheters for all three platforms. Now this makes it a huge inventory to maintain and colossal expenditure. So what we've done at Rawalpindi Institute of Cardiology is that we've removed this 0.018 wire platform from our peripheral inventory. So once we've removed the wire 0.018, we've removed the balloons which are 0.018, we've removed the stents, and we've removed the sport catheters. Everything doing anything to do with 0.018 platform, we don't keep it in our shelf. We only keep 0.014 and 0.035 wire platforms. Then in the balloons, in 0.014 and 0.035 both, what we've done is, instead of keeping both monorail and over the wire systems, we've removed the monorail system and we've only kept over the wire balloons. And in over the wire balloons further, we've removed all the small lengths, we only keep the longest length. So this is how we maintain our peripheral inventory with balloons: 0.014, 0.035, over the wire, and longest shaft length. In stents, we've got both balloon mounted and self-expanding stents in 0.014 and 0.035 wire platforms and the longest shaft length. Now coming to anatomy, we've got ascending aorta, and then here you can see ascending aorta, then this is the arch of aorta, descending aorta, right brachiocephalic artery going on to become subclavian artery, gives off the right carotid as well, and right vertebral artery. Then this is the left common carotid artery, and this is the left subclavian artery, which also gives off the left vertebral artery. So the subclavian artery then continues and becomes the axillary artery, and the axillary artery then goes on to become the brachial artery, and brachial artery in the arm then goes on further in the forearm to divide into radial artery and ulnar artery, and both of these together form the palmar arch, and then branches go towards the fingers. These are the digital branches. Now the best projection to look at, to engage these neck vessels is not the AP view, because here you can see the three branches are not really opening up very nicely as compared to this LEO projection, where the three branches, the arch has really straightened out and the three branches are very clearly visible. So it's easier to engage in the LEO projection if you have to engage any of the neck vessels. Now, subclavian artery stenosis. You only treat subclavian artery if it is symptomatic. Asymptomatic subclavian artery, we do not touch that. So it is not a difficult intervention in a way that all you need to do is, that's a stenosis, you cross your wire, you balloon this, and then you put in a stent and you get the result. Now this is a example where you can see, I'll let you think for a second what's happening here. So just to give you an idea, that's catheter in the right brachiocephalic artery, and you've got an occluded subclavian artery here, and that's the carotid artery going up. So what you see here is actually subclavian steal syndrome, also called subclavian or vertebral steal syndrome. And what you see here is the subclavian is occluded, and it's actually retrograde filling from this vertebral artery, which is then going into the distal subclavian artery here, and the axillary artery is formed. So it's the vertebral artery which is stealing the blood from the cerebral circulation and bringing it into the arm. So this is subclavian vertebral steal syndrome. You can see the same thing here, that if the subclavian artery is occluded, it's the vertebral artery that's bringing blood retrogradely back into the subclavian artery and filling the arm. So this can cause syncope or presyncope related to cerebral hypoperfusion that occurs during arm use. So again, subclavian steal syndrome, now termed subclavian vertebral artery steal syndrome. Now, what do you do exactly? You advance the wire, you do the preliminary pre-dilatation with a balloon. Then you've got two ways. One is to move your sheath further forward across the lesion, and then within the sheath you can bring in your stent and you can unsheath the stent here and then deploy the balloon mounted stent, and that's the final result. Or you don't advance your sheath across the lesion, you just pre-dilate and then you simply bring the stent in and you deploy the stent here, and you don't move your sheath ahead into the lesion. You can do it either ways. Now that's a case where femoral access was taken. This is 6 French 90 centimeter destination sheath. Terumo 035 wire was used and 4 French vertebral catheter was taken for tip injections. So here you can see that's the occluded subclavian artery visible here. That's a pigtail injection. So that's the destination sheath which is sitting into this occluded subclavian segment, and then the wire 035 wire was crossed, Terumo 035, stiff tip angled. This is not the routine Terumo wire that we use in the coronary interventions for exchange. This is Terumo stiff tip angled wire 035 which was used, and then 4 French vertebral catheter was taken on the wire and that easily crossed the lesion, and after removing the wire, this is the tip injection from the 4 French vertebral catheter, and we made sure that we were in the true lumen in the axillary artery. The next step, we changed to an implant super stiff wire through that 4 French catheter to get more support, and on top of that then the vertebral catheter was removed, and on this implant super stiff wire, this is a 6 by 40 millimeter Mustang balloon from Boston Scientific that was used for pre-dilatation. And then this is the result after pre-dilatation. You can see that there's dissection here, and then this is the stenting with Express LD vascular 8 by 37, so 8 millimeters in diameter, 37 millimeter long. This is Boston Scientific balloon mounted stent, and while deploying it, what we've been careful about is not to unnecessarily jail this vertebral origin. So you can see the vertebral artery going here, the stent finished just before the vertebral origin. So it's better not to jail that or compromise the vertebral circulation. So you can come through transfemoral approach as we've just seen in the previous case, or you can even come through the brachial approach, and your catheter is here, you cross the wire, you dilate the lesion and you put in a stent, or you can use both approaches to ensure revascularization. Now this is a case where 57-year-old male patient, arm pain on movement or lifting weight, so he's getting claudication of his arm, occasional episodes of dizziness during work, decreased pulses on the left side, and there is a BP difference in both arms. Arterial Doppler shows monophasic flow in the left subclavian artery, also retrograde flow in the vertebral artery. So this is again subclavian vertebral steal syndrome taking place. So here you can see with the pigtail there's an occluded subclavian stump here, and we've come retrogradely and from the radial or brachial approach, and you can see with that injection that this is the distal segment here. So it's a short segment, not a very long missing segment there. So Destination sheath 6 French 45 centimeter from the left brachial approach. So this destination sheath is 45 centimeter long. It is coming from the brachial approach. Vertebral catheter is coming from the femoral approach. And we've used the coronary wires, coronary pilot 200. That has been used to cross the lesion retrogradely, and then the wire you can see going into the descending aorta. And then this is a coronary 4 by 18 millimeter balloon to predilate the lesion. And then we've brought in, so the whole angioplasty is being done from the brachial approach, but the vertebral catheter is sitting there to make sure that we have a good stent position and we don't miss the ostium of the subclavian artery. So we are keeping a vertebral catheter there for check injections and precise placement. So the wire was changed and implant super stiff wire is in. This is a stent, again express LD 8 by 27 millimeter, and that's a precise placement of the stent between the aortic arch and the origin of the vertebral artery. So we are avoiding both. So here you can see it's just flush occlusion of the flush placement of the stent in the aortic arch at the ostium of the subclavian artery, and it has avoided the origin of the vertebral artery as well. So here you can see the nice placement, and vertebral artery is also safe. Again, another case of subclavian artery stenosis. That's an 8 into 37 millimeter VisiPro stent. This is from Medtronic. And with the help of these dots, it's easy to see that the stent is nicely covering the ostium. Again, you can see over here, nice ostial placement. And in this case, the stent, the lesion was long and it is involving the vertebral artery origin. So the stent is across the vertebral artery origin, but the flow is well maintained and nothing had to be done. So coming to the anatomy in the lower limbs, you can see this is the aorta. Aorta divides into both common iliac arteries, right and left. Common iliac artery in turn then divides into external iliac artery and the internal iliac artery. External iliac artery then goes on and becomes the common femoral artery. And then common femoral artery divides into a superficial femoral artery and a deep femoral artery or a profunda femoris. And then the superficial femoral artery goes on to become the popliteal artery. Popliteal artery then gives off the first branch, which mostly is the anterior tibial artery, and then it continues as the tibioperoneal trunk, which then divides into a posterior tibial artery and a peroneal artery. Another view to show the below knee circulation. You can see here that's the popliteal artery, which gives off the first branch, which is the anterior tibial artery. And then you've got the tibioperoneal trunk, which then divides into a branch going into the middle, which is the peroneal artery, and this is the posterior tibial artery. In the foot, the posterior tibial artery, you can see here, and then this is the peroneal artery, which divides into an anterior malleolar branch and a calcaneal branch. Now, this is the lateral view of the foot, which shows that the anterior tibial artery is continuing as the dorsalis pedis artery, whereas the posterior tibial artery in the foot divides into a lateral plantar artery and a bigger medial plantar artery. Now, this is again lower limb arteriogram. What you see here is almost disease-free aorta and the circulation above the femoral head, iliacs, they are all fine. Common femoral is fine, and then you can see here that the popliteal artery is also fine, but below knee circulation is badly affected. You can see that this is the first branch that comes off from the popliteal artery, and this is the anterior tibial artery, which has diffuse disease and areas of stenosis in it. But then the tibioperoneal trunk, where it was to divide into peroneal artery and the posterior tibial artery, is totally occluded. Now, where do we do the groin puncture? So you must mark, if you're doing it ultrasound guided or fluoro guided, what's important is in the fluoro guidance you have to mark the upper and the lower borders of the femoral head. Now if you put a vertical line between these two borders, then the middle of that vertical line is the point where you want to puncture the femoral artery. Now again, this is the aortoiliac angiography. We can see aorta dividing into common iliac artery, both sides, then common iliac artery dividing into internal iliac and the external iliac artery. Then this continues on as common femoral artery. And then you can see the different branches, like this I here is the deep circumflex iliac artery. And then you can also look for the inferior epigastric artery, because that's the one which causes most of the retroperitoneal hematomas if punctured. Now, what are the possible approaches in unilateral occlusion of common iliac artery? So here you can see this is a left common iliac artery that is occluded. So you can either go retrogradely from the left common femoral approach and you can do the whole procedure from this approach, or you can come from the contralateral side with crossover technique and you can cross your wire here. At times it's difficult if the wire length is not long enough. So what you can also do is, here you can see that the catheter is coming from the contralateral approach with crossover technique. The wire is coming here, and from the left femoral approach, that's a small snare there to get hold of the wire and bring it out of the left femoral sheath, and then that will give you a good grip and solid support to bring in your balloons and stents. Or you can come from the brachial approach and then you can cross this lesion. Now the procedure otherwise is the same as shown in the subclavian artery stenting. You cross the wire, then you can balloon it. After ballooning, you can cross your sheath across the lesion and you can bring your stent in. And once the stent is in and across the lesion, you can unsheath the stent. Your sheath now goes back to this place and only the stent is there, and then you inflate the balloon and the stent is fully deployed. Or you can not cross the sheath, just do the wiring and ballooning and then bring in the stent without taking the sheath across. The sheath, going forward with the sheath and then bringing in the stent and unsheathing the stent by pulling the sheath back actually just ensures the safety and surety that you are across the lesion and stent will easily deploy in that area. Now with self-expanding stents, at times you do need to post-dilate the stents to fully optimize them. How to deploy these self-expanding stents? The inner catheter must not be mobilized. So this hand remains immobilized, fixed, and only this left hand is going to come back and bring this outer catheter backwards, and that will deploy the whole stent. Now this is a case just to show you that there is a left external iliac artery stenosis which is visible here, and that ballooning was done, it was opened up, and then that's the stent, and stent is deployed, and then this is post dilatation in the stent, and that's the final result. Now in this case, what you see here, you can see that's a pigtail going from the right femoral approach and 6 French femoral sheath. The stent placement was done with guidance through injections from STO1 catheter. In this case, we've come up from the brachial approach. This is an STO 5 French diagnostic catheter, 120 centimeter long. With that, we are taking the aortic injections so that the proximal marker of the stent can be properly deployed without missing the ostium. So this STO has come through the right radial approach. So the wire is kept in the left common iliac artery for protection. So usually what happens is, if there isn't much of a disease here, you are okay not to keep a wire there. But if there is disease here and you are putting a stent right at the ostium or slightly above that, there is a high probability that you can crush the other side, and then it might become very difficult once the stent is deployed and pressing on this iliac artery. It may become difficult to bring in more hardware unless you have your wire across already. So if this was a critical stenosis here, or I was more concerned about the disease here, I probably would not leave it just with a wire hanging there which is coming from the STO downwards. In this case, But otherwise I probably would have taken a sheath across this lesion and kept it here, so that there is no doubt that the stent, if required, will easily come in and we will not have difficulty crossing this if it is pinched because of this stent deployment. So you can see here 8x27 Express LD vascular stent from Boston Scientific. This is in place. That's the stent opening up. So once the stent is opening up and the balloon is inflating, you must keep an eye on patient's pain. If the patient goes into pain and it is severe, you must stop inflating the balloon over there, because that means the artery is really being stretched, and what you don't want is a rupture of the artery. So pain is a good sign to see that you don't go high pressure after that. So that's an excellent result with the stent. Now this is another case, which is a 75-year-old man with critical ischemia of the right foot, and he was referred by vascular surgeon for iliac angioplasty. So you can see here, that's the disease there. So we've crossed our wire with a from the right femoral axis, and then on the left side we are protecting the left side not only by advancing a wire but also advancing a 45 centimeter 6 French destination sheath. So that is in the left iliac now. So anything happens to the left, the sheath is across, we can easily bring in a balloon or a stent here and unsheath it and then place it here. So this is just a protective thing, but the wire is crossed from the right femoral axis, and then 8x40 millimeter Mustang balloon from Boston Scientific is used for pre-dilatation. This is Express LD 10x57 millimeter stent, again from Boston, that is being deployed, and you can see over here the stent is being positioned, and then that is the stent being deployed, and that's the final result. That's the final result. So not a significant pinch on the left common iliac, and therefore left alone. Now for crossover technique, you can see here you must advance the wire. The dilator should always lead the sheath. Do not push the sheath alone. Dilator should lead it, and then that's how it goes down. And this is the crossover technique. Now once it is here, you can remove your wire and the dilator from the sheath. So you can even use balloon anchoring technique if the crossover is difficult. Over here, like a guide liner, you've taken an 035 wire which is across, that's the destination sheath here, and you inflate the balloon, you anchor the whole system, and then you can advance your sheath over it. Again, this is a crossover technique, but it's difficult and it is not indicated in the cases of sharp angulated isthmus like these ones, and post-stent graft or post-kissing stents. If there are two kissing stents here, again it's not a clever idea to go by a crossover technique. Now you may have bilateral iliac disease, so it's not difficult. You've got two stents here and they are like kissing stents, and there you can see simply both stents being deployed, and that's the final result. So the technique remains the same: wire, balloon, stent, and if required, post-dilatation. Now this is a case where 6 French femoral sheath has been taken bilaterally and pre-dilated both sides with Mustang 6 into 40 millimeter. So you can see here that's the ballooning being done, and both sides are secure. One has a wire, the other one has a catheter sitting in it. You can see the catheter here as well on the left, and the right side has been ballooned. Now both sides having been ballooned, this is Express LD 8x27 in the left iliac artery and 8x57 in the right common iliac artery, and then stents are being deployed, and that is the final result. Again, 68-year-old gentleman with bilateral claudication, pigtail from the right radial artery with injector. So the pigtail is on the top coming from the right radial artery. With the injector, we've taken the injection. You can see critical disease in the right. Here with the arrows I've fixed the disease, so that's the right common iliac disease, some moderate disease here, and then you've got critical disease in the external iliac artery there on the left side. So two 0.035 wires have been crossed both from the femoral approaches, and then this is the right common iliac artery which is being stented with VisiPro 8 by 27 millimeter stent from Medtronic. There you can see the stent being, this is a balloon mounted stent. So whenever you have to do precise placements, it's better to use a balloon mounted stent. There you can see we've sort of avoided gelling the internal iliac artery. Now moving on to the left side, that's ballooning being done with Mustang 6 by 40 in the left external iliac artery. And then this is the Protege Everflex 8 by 80 millimeter stent. You can see the stent coming here. This is 8 millimeter width or diameter and 80 millimeter long. It's a self-expanding stent that is being deployed here. You can see this stent being deployed. Slowly, gradually, we are moving back and the stent is opening up. And this is from Medtronic. And then Mustang 8 by 40 millimeter post-dilatation was done, and that's the final result. So that's a nice result here and over here. So that's the pre-intervention. You can see the disease, and you can see here post-intervention for comparison. Now, what you do avoid is a stent in the external iliac artery extending into the common femoral artery. Common femoral artery is the groin area where there's going to be a lot of bending forces, and there's a high probability of stent to fracture, and therefore even if you are stenting the external iliac artery, you tend to stop before reaching the common femoral artery. You prefer not to stent common femoral. That's an area where the vascular surgeon can easily do endarterectomy of the common femoral artery. Or there are special stents from Boston, from Abbott Vascular, which can be used. They are interwoven stents, have special radial force, and they can be used in areas where you have bends like the groin and the below and the knee level. So they are sort of kink resistant, and they can be used for this purpose. Now in the crossover approach from the left common femoral artery, disease of the right external iliac artery not extending to the right common femoral artery. You can see here it's a long disease, but it stops before the common femoral here. You can see the femoral head nicely. So we've got to do something stopping here. So there you can see that the stent is being placed, and there you go, that's the stent placement, and the stent has avoided the femoral area, common femoral, so that it's avoided the joint. Now, however, in most cases, ballooning is insufficient in retaining patency, and standard revascularization in common femoral artery disease should be treated by endarterectomy. So that's what I've already said, that endarterectomy is a good treatment option for common femoral, because if you do the ballooning may hold, that's very good, but it may not hold, and if it gets a flow limiting dissection, you may have to stent that, and that's not a clever idea. So this remains a target for endarterectomy. Now this is an AP view for the middle SFA, and this is a DSA image. Now this is AP view of the left popliteal artery. You can again compare cine with the DSA image. And this is now superficial femoral artery being treated with a drug-coated balloon. So remember, anything below the groin up to the foot is preferably treated with balloon angioplasty alone, or at the best drug-coated balloon angioplasty. Cost is a constraint, otherwise drug-coated balloon is a preferable treatment rather than leaving it with POBA alone. And stents are used only for bailout strategies in case of flow limiting dissection, significant recoils of the lesion with balloon. These are the conditions where you use the stent. Otherwise, below-knee, you prefer not to use a stent, but in the iliacs, the subclavians, the external iliacs, common iliac, These are the areas where you prefer to do a stent and rather than leaving with a balloon alone. So very nice result with the drug coated balloon. Uh, Again, as I said, that bailout stenting is done in this case only if there is a flow limiting dissection here. This is ballooning that has been done. There is significant dissection here and the flow was being limited and there was significant recoil after 10 minutes when done. So this case it was covered with a small stent there. So jet stream is another technology that can be used for atherectomy. We have this in RIC and we do it occasionally. It's expensive. So in countries like Pakistan, these devices are a little difficult to use. So that's the lesion here and that's the jet stream being used and that's the result after the jet stream. So right SFA, 6 French, destination sheath, you can see a long missing segment in the superficial femoral artery. I can show you again, there you go, and then that's an occluded superficial femoral artery there. So DSA done in the thigh and below knee levels. So here you can see the missing segment between this point and this point. If you look carefully again, it's occluded here and then that's the distal point where it's reconstituted and again the reconstituted length is seen here. So that's a Teromo stiff tip angled 035 wire and Rubicon sport catheter from Boston. So these two are being used and here mostly you advance with the wire. At times if it's a soft lesion and you push the Rubicon very carefully, the sport catheter, it might just keep slipping and go straight into the true lumen on the other side. But you have to be careful not to apply force, cause perforation or go into the dissection plane with it. So mostly it is led by a wire. So here you can see we've brought it all the way along and it's sitting right here, very close to the distal cap. And then with the help of wire support, without taking the wire forward in this particular case, I've just advanced the sport catheter. It was a soft lesion, maybe a little thrombotic lesion. We've crossed the lesion. I took my wire out and from the sport catheter I've taken a tip injection to make sure that I'm in the true lumen. And then rest is all simple angioplasty. 5 by 100 millimeter Boston Mustang balloon is being used. And then this is we didn't have any drug coated balloons at that time, so this is 6 by 120 millimeter epic stent from Boston Scientific post dilated with 6 by 80 millimeter Mustang. So that's the stent being placed and this is the final result after post dilatation. So very nice result and yeah, so excellent flow going to the foot. So that's the left SFA critical lesion. 7 French destination sheath was used. 014 glide wire advantage has been used here. And this is the jet stream 2.1 by 3.0 for atherectomy. You can call it rotablation of the peripheral interventions. So you can see here how it is moving slowly. It keeps going forward and then you bring it back. So this is the result post atherectomy. And that's the balloon that has been taken and the ballooning is being done. This is 5 by 60 millimeter Ranger drug coated balloon from Boston Scientific and that's the final result. So no stent put in, no flow limiting dissection, nothing, and the drug coated balloon works perfectly well for these lesions. Now this is a right SFA occlusion. 0.035 stiff tip angled wire was taken and in this case Mustang over the wire balloon has been taken instead of sport catheter and the wire is being advanced, but then over here it's not in the true lumen, it's not crossing the distal cap either. So there is subintimal wiring and there is intramural hematoma that we can see here in the picture. You can see very nicely it's all thrombus and intramural hematoma there. So instead of moving on with the 035 wire, we changed over to our coronary workhorse coronary wires. We've brought in a Caravel micro catheter through the sheath and through that we've taken a Pilot 200 and then the peripheral CTO wire, that's a Victory 14. So in peripheral from Boston Scientific, V14 is their workhorse wire and Victory 14 is their CTO wire. So that's what we've used to cross. Then we've crossed the caravel, and with caravel, after removing the wire, we've taken the tip injection to make sure that we're in the true lumen. And then this is a 2.5 millimeter balloon, and through this over the wire balloon, change the wire to 0.035. This is a Mustang 6 by 40 millimeter that was then taken, and this is Protege Everflex 7 by 120 millimeter stent and a 6 by 40 millimeter stent in the SFA, and the lesion was stented. Now, by definition, the popliteal artery ends at the origin of the first tibial artery, which typically is the anterior tibial artery here. So we divide it into three segments. For the popliteal, the P1, the P2 and the P3 segment, and corresponding to that we have the anterior tibial artery, we have the peroneal, and then this is the tibioperoneal trunk, which divides into peroneal artery and the posterior tibial artery. Now, peripheral interventions give you excellent results. These patients are in a lot of pain. What's important to understand is that if somebody goes for amputation of the part of the limb, unless the blood supply to that part has been restored, that part which has been amputated, the wound will not heal. So you have to either amputate from the level of occlusion for the wound to heal, or you need to open the artery as much as possible and you shift the level of amputation either as downwards as you can, or you revascularize it completely and you get excellent result. Look at the condition of the foot here, how bad the foot is. Look at the gangrenous part and all, and how the pre-intervention picture looks like. This is post-intervention. This is just balloon angioplasty, and look at the foot healing after a few months. Similarly, you can do, this is the dorsalis pedis artery that can be accessed percutaneously under fluoroscopic guidance with a micropuncture needle. You can see the dorsalis pedis, and that's the micropuncture needle, and that's being punctured under the roadmap, or you can use the ultrasound guidance to do it. But when accessing the dorsalis pedis or anterior tibial artery, the foot is placed in plantar flexion. That helps you do this, and this is, if you have a CTO which is not being opened up antegradely, then you can use these vessels to go retrogradely. Now again, as I said, excellent results for, look at the condition of the toes. That's the lesion here, that's the anterior tibial artery. That's been fixed, and look at how the foot is nicely healed and with auto amputation. Again, bad condition of the foot, intervention done, no stent placed, that's just balloon angioplasty. So how difficult can a balloon angioplasty be? For cardiology, if you're too busy with your workload, the way we have it in our public institutes, and it's difficult to look after these peripheral patients, even if you don't want to go for very complex CTOs, at least go for straightforward critical lesions and establish flow, and look at the result that you get. Case where both the anterior tibial, posterior tibial are occluded distally, and I went in with my wire and the sport catheter. I was able to cross in, but then my wire tip broke here, and then it's a same retrieval situation as we do in the coronaries. I brought in two more wires, and between the two wires, I'm now trying to twist the other end. The proximal ends are through a torquer, and I'm twisting the broken tip between these two wires. It couldn't come out, then I had to place my wires more distally and then started twisting the wires, and in between them I was able to get hold of this small tip. There you can see the small tip is now nicely fixed between the two wires, and it is going across, and then here you can see it coming out. And there it goes into the destination sheath and brought out. So critical limb ischemia, which is defined by presence of chronic pain at rest, ulceration or gangrene secondary to peripheral arterial occlusive disease. Is amputation the only solution? No. This is a very painful condition, and we must do something early on for these patients. And as I said, the more the revascularization we can do, we can either prevent amputation completely, or we can take the level of amputation as low in the limb as possible.